happy to announce another Anna. This is our keynote speaker. Anne McFarlane is a professor of primary healthcare research at the Graduate Entry Medical School, University of Limerick. She is the first social scientist to hold a chair in academic primary care in Ireland. She has 20 years' experience of using qualitative research methods with a portfolio of completed health services research projects and educational research projects. Anne has been successful in securing research income of over 10 million euro for primary healthcare research and development projects. Anne graduated in psychology and sociology from University College Cork. She completed her master's and PhD in the Department of Health Promotion, Galway. She worked as a research fellow in University College London before returning to Galway, where she held positions as a Health Services Research Fellow and lecturer in primary care in the Department of General Practice. At University of Limerick, Anne has established an interdisciplinary public and patient involvement research group with members from general practice, speech and language therapy, physiotherapy, sociology, psychology, and biostatistics. Anne has specialist expertise in migrant health, working with key academic, community, and policy stakeholders in Ireland and abroad. The Public and Patient Involvement Research Unit has been designated as a World Health Organization collaborating center for migrant involvement in health research. So I welcome Anne McFarlane as our first keynote speaker.
Your introduction and especially for your invitation to be part of your conference. I've actually attended EGPRN before. I worked in UCL, as you mentioned, with Professor Paul Wallace, and we got to we were doing telemedicine research. So I remember attending an EGPRN conference in Gdansk in Poland, and then in Bled in Slovenia, maybe 2001 and 2002. And can you hear me okay? Is that better? Okay. And I remember that this was a very supportive conference and a very stimulating set of days, so I hope that is, and I'm sure that it will be the same for you too. As mentioned, at the moment I'm based in the University of Limerick, and that is in the Midwest region of Ireland. It's a very young university. It's just over 40 years old, and the medical school is just 12 years old. So I'm very fortunate to have a position there as chair of primary healthcare research, and very interested in having a very broad understanding of primary healthcare in the medical school. We're very proud of our campus. We get a lot of rain in Ireland, as you might know, so it's very green, and perhaps someday you'll get a chance to visit us there in the medical school. So in this presentation, there are 4 parts. I would like to start off by telling you why I'm interested in community participation in primary health care. And I was really delighted to get the invitation and to see that this was a theme for this particular meeting. And after that, I want to look a little bit at what the international policy vision is for community participation in primary health care, and then look at what's actually happening in practice. And we'll see that there's a gap. So to finish the presentation, I would like to be hopeful and to concentrate on how we can improve community participation in primary health care, and in doing so, improve services for the community. Okay, so to explain my interest in community participation, I'm going to refer back to the time that I spent in London. And what was great about London, of course, is there's such opportunity to see things and do things. And I have a very, very strong memory of this particular exhibition that I visited, which was called Spectacular Bodies. And it was all about Renaissance art and showing the relationship between medical educators, scientists and artists, and how even though they were coming from very, very different places and different backgrounds, and obviously had very different skills and expertise, their shared interest in the body was mutually beneficial. So the artists were interested in preparing sculptures that then could be used in medical education to generate a new generation of medical doctors and scientists. So I guess I'm inherently interested in collaboration and in this idea that for understanding the body or for understanding health, we need different people from different backgrounds with different expertise to come together and talk to each other. And if they do, that the knowledge they generate will be better, bigger, more comprehensive than if we stay in our silos or stay in our individual disciplines or departments. And I think this is particularly the case when we think about what we know about health and patterns of inequalities in health. And the social determinants of health framework is such an important framework for us to always, I think, hold in our minds when we're thinking about community health, because we know that people's genetic makeup, their age, their sex will, of course, affect their biology, affect their physiological functioning, if you like. But we also know that the lifestyles people lead, the social or community environment in which they're born, they grow up, they work, they live, they play, that this environment for people is also a huge influence on their health choices and their health experiences. And of course, that access to health services itself is a determinant of health. And so, again, if we're interested in really improving health for everybody, it's clear that any one discipline, any one profession can't do this alone, and that there's lots of different kinds of expertise that's relevant. And I suppose this is where communities are important, because they have expertise that we need to understand and respect. So in the talk that I'm presenting today, it's coming from a lot of different places, if you like, and I just want to acknowledge a few recent activities that I'm definitely drawing on for today's presentation. The first is I got a very kind invitation from the Society of Academic Primary Care in 2018 to present their Helen Lester Memorial Lecture. And it was one of those deadlines that forced me to think and get my head straight about a number of things I was interested in relation to community participation in primary healthcare. And that work was very much influenced by my collaboration with academic primary care colleagues for the EU Restore project, which I will talk about very shortly. And then I was delighted to get an opportunity to work with Christos Linos, who was an old colleague from indeed the Restore project, but thanks to a very kind invitation from Esperanza Diaz and Bernadette Kumar, they were producing a very important text about migrant health and a primary care perspective. We know that current patterns of migration mean that there's greater movement of refugees through Europe at the moment. So many family doctors who perhaps wouldn't normally or usually be working with refugees now are, as refugees are resettled in urban and rural populations. So this, I will be drawing on the work that Christos and I did for Bernadette and Esperanza's book chapter as well. And then I want to introduce Adele Tierney, who just was conferred with her PhD in the University of Limerick, and my colleague biostatistician, Professor Ailish Hannigan. So we were working together for a number of years on a project in Ireland about community participation in primary care teams. So you'll see the slides from here on in are very much drawing from all of that work. Okay, so what is the policy vision for community participation in primary health care? Well, this goes back quite a while. When you think of the World Health Organization Alma Ata Declaration, it said very clearly that people have a right and a duty to participate individually and collectively in the planning and implementation of their healthcare. And this attention to both individual participation and community collective participation is important, and I'll come back to that. And we know that this emphasis and interest in community participation is restated, re-emphasised in the Astana Declaration. And what's the rationale for this? Why is it a good idea? Well, primary healthcare reflects and evolves from the circumstances around it, and so the economic, the socio-cultural, the political characteristics of any region or any country and will both shape what primary healthcare looks like and what the communities look like and what they need. So just to play with this idea for a minute, I mean, historically, this is what primary healthcare looked like. In the 1800s, it was traditionally doctors visiting people in their homes, large portions of the population living in extreme poverty, children dying, high rates of infant mortality, and so on. So this is what primary healthcare, this is what a general practice consultation looked like in the past, if you like. And if you fast forward, it looks very different now. We've more female doctors, for example. We've an older population, more likely to have the use of computers in consultations. But this too is a general practice consultation in a primary healthcare setting. So what it looks like, what it feels like, what it's aiming to do changes all the time because of these contextual factors. And from a social justice perspective, if we don't think about including communities to bring their expertise to our work, because they have this experiential knowledge, this lived experience about their health, what makes them feel better, what makes them feel worse. And if we really are serious about addressing the inverse care law, which of course came from a famous general practitioner, Julian Tudor Hart, who talked about the fact that the people who need services the most are least likely to get them. So there really is this need for this collage of knowledges and expertise. So what is community participation? Well, there's a long and a short answer to this. The long answer is there are lots of debates about it. People debate, well, what's community? What's participation? By the same token, there is a fairly stable sense in the literature about a couple of things, and I'd like to draw attention to those here today. So the World Health Organization, back in the early 2000s, emphasized that community participation is a process, and it's about enabling people to become actively and genuinely involved in defining the issues of concern to them, in making decisions about factors that affect their lives, in formulating and implementing policies, in planning, developing and delivering services, and in taking action to achieve change. So, in fairness, the definition has a real sense of vision, but also quite pragmatic, I think, in terms of being action-orientated, problem-solving, and all about improving health. And there's very good work at the moment coming from Australia, from Taylor and Farmer and colleagues, and they would have thought a lot about the concept of community participation and looked at it in practice and say, yeah, it's a very dynamic, process-based process. It's very much about trust and relationships between people. So what I was interested in thinking about recently was this idea of the different spaces for participation in primary healthcare, because of course primary healthcare is very broad, and I was interested in how and when individuals participate and how and when groups or communities participate. So I've talked about these three spaces of participation, and I think there are more, but just for today, of course there's the GP consultation, and if you think of Michael Ballan's work or David Tuckett's and colleagues' work, they talk very much about the patient as expert, the need for this very shared discussion between the doctor and patient. And Glyn Elwyn's work with colleagues more recently talks about this in terms of shared decision making and the value and the positive impact it has on patients' compliance, for example, if they're actually part of making the decisions about their treatment options. And then in the practice setting, depending on the country you're coming from, there are different models or structures that are in place to involve communities and groups of patients in practice decision making. So in England, for example, there are patient participation groups, which are now mandated in GP contracts. In Ireland, we have primary care teams. They're supposed to have community participation on those teams, but actually that's variable. But when practices and primary care services do engage with communities, we see that there is more, that the services are more responsive to the local community's needs, because the practices have a much better idea of what it is the patients and the community's priorities are. and in academic research. So I'm sure you've heard a lot, and there's such a lot of discussion now from funders, from researchers and policymakers about public and patient involvement in research. And this is really challenging academics to say you can't just sit in the university on your own and decide what to research and how to do it. You need to engage with patients and the public and get their perspective on what the priorities are and involve them in decision making about research as well. And some recent work by Edwards et al. From Canada, for example, has talked about a process of involving communities in setting research priorities for primary health care. So this idea of doing all of these things is really clear. The vision is clear. The evidence is strong for the kind of difference and impact it can make. But we have a translational gap, because some countries don't have a clear policy, for example, about the importance of community participation in primary healthcare. That, for example, in Ireland, we have quite good, clear policy in this, whereas my understanding is in the Netherlands, it's less explicit. Where policies are in place, it doesn't mean that there is a lot of resources behind the policy or that there's been a lot of opportunity to implement the policy in daily practice. So, you know, like in England where it's mandated, obviously there's a stronger imperative to involve communities in the practice. And also, when community participation in primary healthcare is enacted, when it is happening, it isn't always inclusive of everybody. And there are these patterns of exclusion where certain members of the community are really unlikely to be part of any initiative. And that's what I'd like to explore next, with a focus on migrants and migrants as part of our communities in primary healthcare. So I'm going to talk you through the 3 spaces that I mentioned earlier, with a particular focus on what we know about migrants' participation in these spaces for participation in primary healthcare. So the first space I want you to imagine in your head is the GP consultation. So perhaps you're sitting in your consultation room. For the purpose of this exercise, I want you to pretend you're in an English-speaking country, and your next patient walks in and says this. And then the next patient comes in and says that. First patient is Polish, who's talking about a pain in her chest. And the second patient is Portuguese, talking about a problem in her back, a sort of pain in the back. Now, on the one hand, both of these symptoms could be mild, self-limiting, benign. You know, they could pass very, very easily. But in either case, they could be indicative of something much more serious, like a heart condition or a spinal tumor. So the need for a really careful history taking and understanding of the symptoms and involving the patient in the consultation is extremely important. But in many countries in Europe, GPs do not have access to trained interpreters to help them and to support them to do what they're able to do very well, which is history taking and using their communication skills, conveying empathy to patients. So depending on your setting, and you may be very familiar with what I'm describing, and from the research, GPs have told us they often have to muddle along. They have to get by, maybe by relying on body language or gestures to try and figure out where this pain is exactly, how long it's been a problem. Often GPs have told us that they have to rely on family members, including children, as interpreters, or friends of the patient as an interpreter. And while that can be supportive perhaps for the patient, many interpreters don't have good English or good knowledge of the local language themselves, and they're certainly not trained to interpret. So they're not trained, for example, they're not working to a code of ethics or anything, or have any professional standards around how to participate in a 3-way consultation. So what this means in practice is that migrants' participation in shared decision-making, for example, in general practice consultations is usually very, very difficult to achieve, and it's not very common. So let's have a look at the next space for participation, the practice setting. And what do we know about migrants' participation here? Working with Jess Drinkwater, who's a GP at the University of Leeds. She's just finishing off her PhD this year, and her lead supervisor is Professor Robbie Foy. And Jess is interested in patient participation groups in English general practice. And when she has reviewed the literature in this area, and even in taking her own research forward, what's very, very clear is that often in an English setting, the groups or the communities that get involved in practice participation are white, middle class, educated, maybe heading to retirement or retired. So, of course, they represent themselves and people like them, but they don't represent always the diversity of the neighbourhood they come from, or certainly not the diversity of the region or the English population. And so there isn't a good representation of ethnic minorities or migrants in these structures. And in the work that I mentioned earlier that we were doing for Adele Tierney's PhD, where we looked at community participation in Irish primary care teams, we found one example, a good case study, if you like, of where migrants had been involved in a local primary care team. And it was valuable and successful in many respects, but there were challenges, of course, because migrants had transient lives themselves. They weren't necessarily settled in the town that the primary care team was based in. And so there were challenges in developing and sustaining migrants' participation in primary care teams in Ireland. Finally, if we look at the third space for participation in primary healthcare, the idea of academic research. So what do we know about migrants' participation in public and patient involvement, for example? And actually, it's pretty bleak. It is very, very rare to see examples of migrants' involvement with academic researchers and with clinicians and other colleagues. Of course, researchers say, well, we would like maybe to do this, but there are language differences, there are cultural differences. Some of these particular migrants are very, very hard to access, hard to reach, or maybe easy to ignore. That's the question. And Maria van der Musenberg in the Netherlands has done really important work looking at the specifics of how to involve undocumented migrants in research and service development. GPs, of course, and health researchers ask about the time problem, the time commitment. And as Anna has outlined already in her opening this morning, time is, I know, your most precious commodity and your most challenged resource. And there's maybe perhaps an element of fear for health researchers or for GP researchers saying, well, what will it be like researching with migrants? Because there can be a sense of othering, that migrants aren't just like any other patient, or they're not just like any other community, but of course they are. It's just they happen to have moved from one place to another as part of their life journey. So this othering can introduce, a sense of distance, maybe a sense of stigma, maybe a sense of fear. So I did mention that I would finish on a hopeful note, and I am interested in how we can improve community participation in primary healthcare in general, and particularly for migrants. And I think what's really positive is that we have a lot of resources available to us to do this. We don't have to start from scratch, and we don't have to reinvent the wheel. So in our work over the last number of years, we've been drawing on available literatures and methodologies and applying them to academic primary care in Europe. So the main tradition, I suppose, that we've connected with is called participatory health research. And participatory health research is actually a paradigm about, what is knowledge and how should we view our world, basically. And what participatory health research says is that the idea of participation and partnership is at the center of knowledge. And so it's not an add-on, or it's not, handy if you can do it or handy if you can fit it in, but it's integral to what we need if we're interested in knowledge. Participatory health research is saying, look, research isn't done on people. It's not about viewing people only as passive subjects, who will give us data that we can go away and analyze. It's much more about working with people and doing research with them so we can work to improve their lives. So in this paradigm, the entire research process is viewed as a partnership between lots of different stakeholders. So that might involve a mix of academic researchers, professionals in the field of healthcare, doctors, nurses, receptionists. It could involve members of civil society like NGOs or community organisations, and also policymakers, service planners, people in the health service who are making decisions about budgets and services and structures. So the ideal participatory health research project, if you like has this diverse group of people coming together to look at a problem and to find solutions. And what I really like about participatory health research is that it's very influenced by Paulo Freire, whom you may be familiar with. He's a Brazilian, he was a Brazilian educator, and he was particularly interested in inequalities and the importance of community emancipation and community participation. And I love this quote from him because he highlights that, of course, the structures in our research world or in our practice world may not be set up very well for dialogues. But then the structures need to change rather than us sort of throwing our hands up in the air and saying, well, we'd like to, but we really can't. When you get involved in participatory health research, there are a lot of common pitfalls that can occur. And this is something that Christos and I worked on in our book chapter together. I mean, the first thing is that partnerships can be set up, but they can be quite hollow, tokenistic. They're there on paper, but actually they're not very meaningful. And that's really not helpful, and it's not productive. So partnerships need to be developed with care. And there are guidelines from the Canadian Institute of Health Research, which really talk stakeholders through all the different aspects of their partnership that they need to think about in advance to make it a meaningful one. The other thing is that stakeholders who get together like this need to be on the same page. Like, as you can see, even as I hear myself with all the different examples that I'm using in the presentation, I mean, community participation in primary healthcare can mean an awful lot of different things. It depends if you're thinking about the individual level or the community level, or you focused on participation in the practice setting or at a more neighbourhood community health region. So in our work, we've produced a framework for community participation, and the idea of that is it's a series of questions and activities that stakeholders can do just to clarify, what are we doing here? Do we all have the same understanding of our this particular community participation project? Do we all understand our roles in it? Do we understand how we want to take it forward? And I suppose through all of this, it's essential that the conversations between stakeholders and that the dialogue that people have together is meaningful. Again, that it's not tokenistic, that you're not pretending to share decisions or pretending to be interested in someone's expertise if in fact you're not. So there's a really interesting set of tools and techniques called participatory learning and action research tools and techniques that we've used in a lot of our research over the last 10 years. And I'd like to describe that for you now as we move towards the end of the presentation. Participatory learning and action research, if you like, is an approach that fits within the paradigm of participatory health research, the broader one. And there are a number of things about it, and I hope that as you read through these, you'll see why I think they have such relevance for community participation in primary health care. So first of all, it's a very practical approach to research. And it's about bringing diverse groups together where asymmetries of power may exist, where you say, we know that these groups don't necessarily meet together and that there's different power relations between them and they're in the room, and therefore we need to think about that. I mean, it isn't often that, a community member would sit beside a policymaker and feel we can make a decision together. Or if there's a doctor and patient working in the same group, well, you have to think about the usual power dynamics that exist in that relationship, and how do you manage that if you're trying to create an equal forum for dialogue and decision making. So participatory learning and research is inherently interested in this. It asks people to concentrate on identifying shared problems and shared solutions. So the solutions must work for everybody. It's inherently interested in reciprocity, mutual respect, cooperation, and dialogue. And then it has a range of techniques that can be used to ask groups to come together and both generate and analyze data together. And these techniques are very inclusive, they're very user-friendly, they're very democratic. So you may be very familiar with using interviews, qualitative interviews, or qualitative focus groups, for example. And they're really valuable methods in a research process. But what this set of tools and techniques offer you is another set of ways of generating and analysing data in groups. I'm just going to give you some very short examples of the kind of techniques that exist, just to concretize it a little bit. I mean, there's one technique which is called a flexible brainstorming. It's a fairly fast kind of exercise, and it really would give people who've come together an opportunity just to generate information, get the ideas on the table. And you would usually use pictures or notes to convey an idea in order to literally put it on the table. Card sorts then are a very interactive way whereby everyone who's just generated the data starts analysing it thematically, saying, you know, what are we saying here? Are we sometimes talking about the same thing? Are we sometimes talking about something different? And then a direct ranking exercise, which is often very useful when you're actually trying to make a decision. It's a very transparent and democratic way of actually allowing people to vote and to rank you know, their preferences. And then people can all see each other's preferences, and they can see how the collective vote has ended up, if you like.